Next, we are going to hear from Ms. Kelsey Simmons. And Kelsey is an evaluation associate at EnCompass LLC, where she conducts both qualitative and quantitative evaluations of large international and domestic projects. She has lived and worked throughout sub-Saharan Africa, researching, designing, and evaluating programs in HIV/AIDS, water, sanitation, malaria, and health system strengthening. And Kelsey led the AIDSFree review of GBV in Tanzania, so we will hear about that now.
Good morning, everyone. I'm going to present some of the highlights from the GBVI in Tanzania. And as Floriza mentioned, unfortunately, due to time, there will only be highlights, but hopefully there'll be lots of time later for expansion and question and answer. So this review was undertaken with collaboration with Zuki Mio, who is a local consultant in Tanzania, but unfortunately couldn't be here today. Oh, wrong way. Sorry, a little technical difficulty. Is it right? Okay, there we go. Oh, sorry. It does have a mind of its own. Okay, sorry about that. So the GBVI Tanzania review was undertaken with significant document review, as well as data collection with over 60 stakeholders within Tanzania. We were also able to conduct a participatory focus group with all 19 implementing partners while in country, as well as being able to visit 2 sites in Iringa, a one-stop center that was operating there, as well as a police gender and children desk. So GBV and HIV in Tanzania, as has been mentioned in previous reviews today, is quite a large issue. So just a highlight for me is the 44% of ever married women that have reported experiencing physical or sexual violence from a partner in the 2010 demographic health survey, as well as the fact that almost twice the HIV prevalence in Tanzania is almost twice as high for women at 6.2% as men. So the GBVI in Tanzania took a focused approach. Because Tanzania is such an expansive country, the GBVI in Tanzania decided to focus on 4 regions, which are now actually 5 regions. As you will see, Iringa and Njombe were 1 region at the beginning of the review and split into 2. And they focused on these 4 regions based on the following reasons, which were high rates of GBV, high rates of HIV, and U.S. government presence and current USG HIV activities that could be expanded on. So as has been mentioned, one of the key objectives of the GBVI was to ensure that GBV activities were integrated into existing HIV platforms. So for this reason, these 4 regions were chosen. And just a little bit of background, the GBVI in Tanzania was a $24 million 3-year initiative, that $3 million of which was dedicated to the Tathmini GBVI, which I know Susan will talk about after this presentation. So first I'll just highlight a few of the key contributions of the GBVI in Tanzania and then go into some of the reasons of why and how these contributions were able to occur. Again, not extensive, but just a few highlights. So the GBVI in Tanzania used a socio-ecologic model and really operated on each level. So on the policy level, there were 2 key guidelines that came out that were really the basis of a lot of the training guidelines and curriculum that came after them. These 2 guidelines noted were really ensured the integration and operationalization of GBV services into the health facility, targeting HIV service delivery points, and engaging social welfare officers and police officers. At the institutional level, some key highlights, one that I'll just point to was the revision and training of the police form number 3. This is a form that's filled out by doctors after a survivor is referred to a health facility and is used to be able to document and present medical evidence in court. Although there's still work being done on it, one of the key contributions of the GBVI was to work with the Ministry of Home Affairs, where the police fall under, to revise this form and then have a multisectoral training where they brought police, healthcare workers, social welfare officers all together to be trained and be able to use this form more successfully. At the community level, there were a lot of reports of very successful gender transformative trainings, such as Men as Partners, Couples Connect, and the Family Matters program. The first two of which use the SASA methodology to really engage gender transformative training at the community level. Another example of how kind of one intervention really went from the national, institutional, and community level was in the building the evidence base and harmonizing PEPFAR indicators within the government of Tanzania. So one of the GBVI partners was aimed to really work closely with the government of Tanzania at the national level and to harmonize PEPFAR indicators, which did change throughout the initiative, into the national healthcare system. Into the national health systems. And then after these were integrated into those systems, they then worked to train healthcare workers at the institutional level in ensuring that the indicators were used and collected and reported. And then at the community level, as I was there, they were working on the creation and dissemination of community-level data collection tools in order to gain information at the community level. So how some of these contributions were able to occur was really a lot about coordination and collaboration in a variety of ways. So in the first was really the USG interagency collaboration. The GBVI used an existing PEPFAR structure, which designated different USG agencies to lead the majority of work in specific regions. So at the national level, the USAID and CDC coordinated with the government of Tanzania to manage, plan, and implement activities across the 5 main pillars of the GBVI: clinical services, prevention and community protection, enabling a policy environment, coordination, and research and evaluation. Then there was one key USG agency that was responsible for coordinating within each of the 4 regions with the implementing partners in their regions, and then also reporting back to the national level and ensuring integration across and to avoid replication. Another way that this was found was really in the multisectoral synergies. So from the beginning of the initiative, the GBVI really wanted to engage some non-traditional agencies, ministries, such as the Ministry of Home Affairs, where the police fall under, and created quarterly GBV meetings where the Ministry of Health and Social Welfare, the Ministry of Community Development, Gender and Children, the Ministry of Home Affairs and TAC-AIDS, as well as the GBVI all came together in order to report on some successes, challenges, and lessons learned, and able to ensure that their programming was going down to the institutional and community levels as well. Finally, in terms of the implementing partners, there were 19 implementing partners throughout the GBVI, and one of the successes of the initiative was really in coordinating across these partners. So this model here actually shows that following feedback from some of those national quarterly GBV meetings that really were asking for more leadership and coordination among partners at the regional level, this model was created where there was one national implementing partner that was leading each of the key pillars of the GBVI. So a clinical partner that was the lead of clinical, a prevention partner that was leading at the national level and coordinating there. And then there were regional leads of each of these implementing partners. So there was a clinical and prevention partner at each of the regional levels whose job it was to coordinate with the government of Tanzania to ensure that there was harmonization in their region, as well as linkages between clinical and prevention services and within the region. So this is, I think, one of the models that came out of the initiative that was really useful in ensuring that there was close collaboration and coordination across partners, as well as ministries and USG agencies. And that is all for now. Thanks.